Okay, streaming.
Hey everyone, welcome back to another session. Today we have the amazing Dr. Devin. She's an orthodontist and she does so much more than just that. I've seen the PowerPoint a little bit. I'm so excited. So take it away whenever you're ready.
Well, thank you so much. It's truly an honor to be here. Greetings from the future all. I am hailing from Japan. So yes, if you look down at the bottom corner, that is me from a town not too far from where I live. That's Miyajima, and I'm also commander of the Navy, so I'll share a little bit about that. And I'm stationed at Marine Corps Air Station, Iwakuni, Japan. So if you think of Japan, the size of California, but with a third of the population in the US, that is Japan for you. And I'm at the very bottom of the main of the 4 islands. Because I'm in the Navy, and I do need to share this, these are my views and not the views of the Department of Defense. So again, feel free to ask me anything. And at the end, if there's any questions or areas you want to touch upon or privately, my information will be there. So what I'm going to discuss today is, my education, my journey. I went from a general dentist to being an orthodontist, and I had a chance to look through some of your amazing speakers that came before Dr. Foster, Dr. Eisenberg. There's one, I'm blanking on her name, that was in DC, because I really wanted to give you guys different information and a different perspective than kind of what you've seen before. And you'll definitely see my decision why I decided to specialize. I didn't go straight from dental school into residency. The scope of my practice, when to refer, because I think it's nice if you guys start seeing these things now so you can start training your eyes to look for things. What practicing the military looks like, where we're located, some different areas of orthodontics you guys didn't have from your previous presentations, some case examples and questions. And then just to put things in perspective, the bottom left photo is actually the first photo of one of my very first patients she took with her iPhone when I was in residency. So I also do have some YouTube links on this presentation that I do have highlighted that'll take you to different things that I actually use in my own practice. They're not mine. And again, no financial interest here, only on one item, and I'll go to that when we get there. But I just wanted to let you know there's some areas I may not go as deep into because I just want to give you a chance to look at this, and I'm giving this presentation free for your organizers to use. So again, thank you so much for having me. I really do appreciate y'all reaching out to me, Adam, Mahuri, and Tracy. So I started my degree, my education at St. Mary's College of California, and I got my bachelor's degree in communications and minor in science. And I will tell you, going to a Catholic school, you walk in and they tell you not even God gets an A, and they mean it. And they have a sliding grading scale. And why this is so important that I tell you is that very often grades are one of the things that people look at a box to be checked. And my grades in college were much lower than dental school because of that sliding grading scale, meaning I was in a class where they'd only give 2 A's, and it didn't matter if you had a 95. If 2 other people had 98s, guess what? They got the A's and you got the B's. And so I purposely did things to make myself stand out. And because my major was in science-based, this is just a copy on the below left corner, tells Shodu, exploring effective communication strategies dentists use in public healthcare. This was the dissertation that I did for my bachelor's degree that I proudly carried to each of my dental school interviews because it really showed who I was and what I wanted to bring to the profession. I fell into dentistry not because I wanted to. My dad was a dentist in the Navy, and I never dreamed I would drink the Kool-Aid as much as I have. Now 15 years in, but I'm telling you this because I want you to kind of keep your eyes wide open. And for me, what really started my journey in becoming a dentist was a little girl that I saw when she was 7 years old and I was 20, helping my dad on a mobile van and seeing how dentistry really can impact people's lives and realizing going to dental school could open up so many different avenues. And hopefully that's something you've seen with the different specialists, different ways you can practice. And so when I was applying to dental school, knowing that I didn't have as high grades and knowing that I had to be really strategic, of course you have your dream schools, but I only got into 2 schools and I was waitlisted. And UNLV was actually a brand new dental school. At the time I was the second graduating class, but I had an in-state residence. And I'll tell you this, I'm not a cold weather person. So interviewing at another school, they told me 25 degrees was warm, and going to UNLV, and even though they haven't seen their full accreditation, they were the first school to offer me admittance after I got off the wait list. And that happened in about April of 2003. And going from a private college and then going to dental school is a lot of money. I don't know if the numbers have been shot, but I'm now hearing numbers of people being debt close to $1 million after residency. And so I looked into a scholarship with the Army, the Air Force, and Navy. They all offer this. And I will tell you, the Health Profession Scholarship Program is something that I am a firm believer in. I don't get any financial interest, but I do a lot of recruiting for the Navy. I have looked, now I'm at the point where I sit on boards, people applying, and it doesn't matter how expensive your dental school is. So if you want to go to your dream dental school that's $150,000 a year, guess what? The Navy will pay for it if you've got that scholarship. And there's a couple different other versions of the program that I can kind of go into. So I was on a 3-year scholarship, and I graduated with about $80,000 of debt for my first year and for my boards. My state licensing boards. And, just to touch briefly on the Navy, you pay back year for year. So anyone who tells me, unless they have a very well-off parents, that they can get their entire college and dental school paid off in 3 years, I would love to meet them, because I don't know anyone who can do it that quickly. But what you do is, in turn, you give them years of service. So in turn, I owe the Navy 3 years as a dentist, also getting paid, also having a job, also during the time when I was waiting for my license to go in effect as soon as I graduated. And, you have to be okay if you join the Navy or the Air Force or the Army deploying. You have to be okay moving. You have to be okay not having control of your life. And I say that because there are sometimes people you go to San Diego for 3 years and be done. Sure, but you could also do some other things. And I'll touch a little bit on that. So I just want to make sure people have their eyes wide open. And it's a little different in the Army, the Air Force, but it's still the same concepts. When I was in dental school, I thought I wanted to be a pediatric dentist, and I actually got into a couple pediatric residencies, but it didn't align with the military, and everything happens for a reason. And so what they encouraged us to do is, and I encourage anyone to do this, when you come into the military, when you come into like private practice or out of dental school, you can't learn everything. There's going to be some areas you're going to get great experience. And so doing a GPR, general practice residency, or advanced education general dentistry is something I would encourage anyone to do, military, civilian, because it helps supplement the areas that maybe you didn't get as much, practice in. Because your first 2 years, you're buried in the books, and the next 2 years, you're seeing patients, and it's really the luck of the draw of what you get. So in dental school, I got tons of extractions, but I didn't get a lot of denture cases, and that can vary by school, by location. And one thing I do want to stress is going to dental school, not having a science major behind me was challenging at first, because what some of my colleagues had already seen was brand new to me. However, if you're willing to work hard, you're willing to, find ways, and I battled test anxiety in dental school. I had to figure out different ways to study. And so after I got my AGD certificate, I'm now in the military. You'll see there's a break because I didn't graduate from orthodontics residency till 2012. So after I did that, I was 2 years of me being operational as a general dentist, and then I went into orthodontics. I never had braces, never dreamed I want to be an orthodontist, fell into it, I'll go to her. And then 4 years later, I became a diplomat of the American Board of Orthodontists. And actually next year, I'm looking to recertify a couple years early with one of my colleagues. So to become a board certified orthodontist has definitely changed a lot, especially with the pandemic. It used to be starting and finishing cases, and orthodontics takes on average for these board cases 2.5 years. So that's definitely why there was a break. Do I have any questions from anyone before I go to the next slide? No? Okay. All right, so why do I stress being a general dentist first can be a really good thing, is it avoids you having tunnel vision. We all went to dental school. We are all going to take this Hippocratic oath of taking care of people. And it's nice to kind of be a jack of all trades and kind of understand the lay of the land, having a good foundation. And so these are real pictures of me from pre-deployment training and actual deployment training in Iraq. So I served at Operation Iraqi Freedom. I was at Al Asad Air Base in 2009. And what that did is it trained you really how to handle things in very austere environments, like doing a root canal with a paper clip and learning how to take out teeth and not having sand everywhere and giving everyone antibiotics, things you probably wouldn't do here or do in a country that's not a third world country, but it really challenges you, and you get to learn from a lot of great individuals, and you have the best patients. Many of the people that you treat in the military don't have healthcare growing up, weren't able to afford seeing a dentist. So you have someone who's very grateful, someone who's very healthy, and a really just thankful population. It was during this time and right before I was graduating dental school, I kept getting told I had the personality of an orthodontist. And I'm still trying to figure that out, but I would say it's definitely probably someone who's very energetic, who's a people person. And that really solidified when I started working with the oral surgeon. So in the photo on the right, the gentleman who's to the right of me, who is on the sign where the closest on, I guess it would be the right side of me, with closer to the L of the dental. That's Mark Ransard. He's now out of the military, but he was in the Army, and he was the only oral surgeon for the entire region. And I'm going to tell you, the bombed out, like shelter, that was our dental clinic. So literally, I mean, a very, very different side of practicing dentistry. But there was times on deployment where someone took a bullet and I remember this gunshot to the face. The guy's tooth, he lost the tooth, but it saved his face. But we had to put things together, and I really fell in love, which I call the dark side of orthodontics, the surgery, the things that you can do to really change people's lives. And so while I was on deployment, before you go to residency with the military, you have to do what's called duty under instruction, which means, okay, hey, big Navy, I want to leave the Navy for a couple of years, specialize in X, Y, and Z, and then I'll come back. And the military pays for it. You just have to go through a board, and after that, then you can apply to residency programs. And some people do it and get successful the first time. I was very lucky. I was successful first time, and other people didn't. And then what I also did was, while I was in Iraq, I interviewed for residencies on Iraq. So I didn't have to buy plane tickets, didn't have to get suits. I was waking up at 2:00 in the morning to do it, but it worked out really, really well and beautifully. And so why am I an orthodontist? Being an orthodontist is like being a quarterback on the football team. You are working with so many different people. Very often in my day-to-day job, I am either dealing with someone's command, which would be maybe someone's family. I'm dealing with different dental specialists, and we're trying to figure out ways to make things work. And again, you form relationships with your patients. You're married to them because you're with them for a couple of years. And especially the more complicated the cases, the more it requires of you to multitask. And that is my personality. I love having a couple things juggle at once. But it also, by doing that, you get to see people grow and change. Like, I can't tell you how many times I have patients who are now smiling, even though the braces just went on, because now they can feel like the changes are happening. It's almost like the road construction signs around. So you know something's coming, but you're not quite sure. And then, especially in the military with the communities I work in, you become a role model in the community because you're meeting so many people. And even though I'm in scrubs, and some of my patients may not know I'm in the military because I wear scrubs and gym clothes and a white coat and not so much the uniform that you see here, is you get to get invested in the community and you get to know people. And to me, I think that's one of the great things. And it allows you to do other things. So as you can see from the bottom, I have a history in pageantry. That is taken from the Midway that I did at an event on. And then obviously my co-residents at the bottom, us just having fun and being goofy. The other reason I would encourage, what I love about being an orthodontist, so in the military, you really get to be a leader in your profession. So right now in the military, only 18% of the women are in the military. And at my rank is Commander 05, or would be considered a Lieutenant Colonel in the Army, the Air Force, Marines, there's only 0.29%. However, in my actual orthodontic specialty, over 50% are women in the civilian sector. And actually in Navy orthodontic community, there's only 14 of us in the entire world. Over half of us are women. And what's beauty about it is it's giving you a lot of opportunities. So they're always looking for ways for me to speak. So I spoke at the American Association of Orthodontics this year in January. I was one of their main speakers. I've spoken for STEM, and then also doing this allowed me to publish a book. So I will admit financial interest here. This is a copy of my cover of my book. If anyone's interested, I can send them a link on Amazon. But I felt I had the time to do this, being an orthodontist, where I feel like other professions it may be a bit more challenging. Anything can be done, anything impossible can become impossible. But I just want to show you that doing these other activities will spill into orthodontics, because you'll find yourself telling stories to your patient. You'll find that it makes you interesting. And that's just a little bit there. As we go into what orthodontics is, I took this definition off of the American Association of Orthodontic website. And most people don't realize there's actually two versions of the website. There's one called braces.org, and this is where I would say the lay person would go if someone was looking for an orthodontics. And this is basically what they put about, the diagnosis, the prevention, the correction of a bad bite. The orthodontist goes to school for a couple extra years, and they're trying to help your teeth fit together. So not only do you have a beautiful smile, but something that you have the confidence in, something that you can function and chew all the foods that you love, including the ones you're not supposed to eat. And, some of the concerns that people come, or, it could be braces or aligners. And I want to make it very clear that aligners are still active orthodontic treatment. I think in this day and age, people think they're not, but they actually really are. They're still moving your teeth. And so this is going to help if something's crowded, something's spaced, something doesn't quite fit together. And, I would say that orthodontics has really changed. It's not so much about just treating children and teenagers, but I see people and treating people all well into their 60s that are getting braces. Because let's be honest, having a beautiful smile is something we all want, whether you're 8 years old or 80 years old. And I don't feel like that's something that people would fault you for. It's something that I think we all want and have. And hopefully you have your teeth for your whole life. That's how we even diagnose you when you enter the next chapter. So, one thing I wanted to show here, and I saw this mentioned a couple lectures, but they mentioned about, referring to orthodontists at age 7. And this is actually a chart that I got from the American Association of Orthodontics, and it shows a few things that I wanted to point out to you. The reason why all of these are important to see is that orthodontics is a lot about timing and sequence. And what I mean by that is, there's a few things that we tell people to send to us. So you could see this, and I'm sure anyone here could see this, whether they have a cousin, a friend, a teacher, or someone they work with that see this. So the upper two talk about crossbites. Now, I'm sure everyone here has got a pair of shoes in their closet. And when you bought your shoes, I'm going to, show you how this is similar, but the top goes over the bottom. And that is how it is in your mouth. Your upper jaw should go over your lower jaw. And as you can see right here on the upper right, I don't know if my clicker is working for you guys to see, but right here for the anterior crossbite, you see it's the opposite. The bottom goes over the top. And you see this air over the side. The reason why this is so important for us to treat right away is that, as you could tell here, this tooth is losing all the gum tissue. So if we can get in there and treat it right away, we could potentially save this tooth and further any sort of gum loss or bone loss. With these posterior crossbites, people grow in 3 different directions. They grow widthwise, which is called transverse, anterior, posterior, front and back, and vertical. Why this is important is I always tell patients at certain ages, there's certain things that we can catch and treat. And at age 7, there are certain things that we like to get on right away, or at least monitor watch. Crossbites are one of them. Oral habits down here at the bottom, sucking your fingers, sucking your thumbs. So for something to cause changes in your mouth, you have to do it for 6 hours a day or longer. Why is that important? Well, I know they're showing a child here, but I had a hairstylist who used to always have bobby pins in her mouth, and she would have them in the same place. And even though she was an adult and gun growing, because she did it every day for so long, guess where she had a gap in her mouth? Where she had those bobby pins. And so anything that we do, especially for a long period of time, will have an effect. And at a young age, what it can do right there with oral habits is it can actually cause a narrow upper jaw, narrow maxilla. And that's what you see actually with the posterior crossbite right here that I'm circling with my clicker. Crowding is something that we can see pretty much at any age we can treat. But again, it's more just getting the patient in the chair and us educating them. And there's also some skeletal issues that you can see. So right here, this person has a very forward upper jaw. And they might have what's called people call it an underbite, but it's called reverse overjet or a class 3. Why is that important is that certain, in your skull and in your face, there's sutures, they're called frontales. And what happens is that they will fuse at different points. And the ones that affect certain jaws will fuse at a younger age than later. So if it's something where we can do something now, then we will, and then we'll actually look at doing full braces later. So again, I just kind of want to show some of these things that we kind of look at. So if you see them and you're in dental school, you're like, hey, I think they need to see an orthodontist. They'll be very impressed because you're not even a dentist yet and you're already catching on to these things. So where in the world are military orthodontists? And I'm going to focus on the Navy. So we do have more orthodontists in the Army, the Air Force. But actually the picture below on the lower right is many of my Navy orthodontists. Some of them are actually just recently got out, but that's probably the most I've ever seen at any conference. That was in Los Angeles in 2019. And we have a different job depending where we are. So as you can see in the States, we're located in California. Texas is where we actually have our training program. And if you recognize it from earlier, that's actually where I did my training. It's a tri-service program, meaning we have Army, Air Force, Navy. We're located in Norfolk, Portsmouth, Virginia. We're located in Bethesda, Maryland. That's kind of in the DC area. And we actually have a postgraduate dental school there for other programs, whether you're interested in perio, oral surgery, you name it. Annapolis, which is the Naval Academy, and Lejeune. The reason I mention all these, including the residency program, is right now very much in the military, a lot of people do train with the military, and some people feel like, oh, is that shading you or shielding you from other things? I will tell you, in the military, we actually work a lot with the civilian program. So we've had, rest in peace, Dr. Prophet, he came to our program in San Antonio. We worked with a civilian resident. So it's really, you really got a full breadth of what you're going to do, and it just really changed in location. So when we're in the States, our focus is adults, active duty. Very, very rarely would I ever treat a child, and if I was, it would be something for a board case or something that would be very limited treatment. But mainly we do surgery cases and we do full mouth rehab. And the reason I say that is that's probably very different than some of the practitioners who've come down here about their practice. But I find it's a great puzzle. I love working with, I love being part of a team. And this kind of goes into the concept where we're providing care and treatment for people who probably couldn't afford it. I'm not sure if many people are familiar with orthodontic surgery, but it's actually not covered by a lot of insurances. So in private practice, I know my colleagues sometimes have a harder time selling it to the patient, where for our patients, it's free. And it's always really nice to do that. And we work hand in hand with the oral surgeons. So we're part of, I'll give an example. I have a really great case to show you guys later. So where we are overseas, so we're in Japan. I'm actually coming from Iwakuni, but Okinawa, which is like the version of Hawaii off of mainland Japan, and Yokosuka, which is outside of Tokyo. We're also located in Italy. So before this, I was in Sicily, so the island off the boot, and Naples, and then we're also in Rota. And this is my family. As you can tell, I really drank the Kool-Aid, all Navy family, my dad, my brother, and my mom for my graduation. And overseas, I would say be more similar to private practice, as we're treating children and adults, but there are kids that are of our military members. So active duty, families, anyone who transfers in with braces, they definitely take priority. And our focus is really, especially with the kiddos, is that we want to try to see if there's anything we can do that we're hitting their growth, where we can kind of intercede and maybe prevent teeth being taken down the road, or we can prevent them being jaw surgery, or something where it's a limited treatment, what I just showed earlier, when to refer. And so that's really our focus now. As I told you earlier, there's only 14 orthodontists in the Navy in the entire world. And even on each of our bases, there's probably a lot more people that want braces and there's only one of me and only a few assistants. So we do have a board. And even though we can't say yes to everyone, people can go out in town, and we actually work with local civilian orthodontists. So here in Japan and Italy, I worked with local orthodontists. I can't say that as official capacity, but we have a thing called TRICARE, where the military will pay for a portion of the cost, and that works for pretty much the kids as long as they're a full-time student until 23, which is nice that they do cover a cost of that. So kind of going into some of the treatments and some of the things that I do, growth modification is something that's a bit tricky, and very often it's because we're looking at pubertal growth where when you go from a little girl to a woman, a young boy to a man. And very often as orthodontists, we treat girls too late and boys too early. And what I mean by that is very often I will have a patient who sits in my chair, and she may be 10 years old. That's what her biologic age says, her birthday says, but she may look like she's 16. She may have hit puberty early. Or in her mouth, her dental age may show that she's only 11 or 12. And the reason why growth modification is helpful is that we're helping out a discrepancy between the upper and lower jaw, a skeletal discrepancy. And what you're seeing examples of here are actually headgear. So you're seeing headgear from the bottom that's wrapping around that's helping out with the discrepancy. It's called for skeletal class 2, as well as the one on the far right. And then you have one in the middle that is reverse pull headgear, that is dealing with someone who maybe has a discrepancy where their lower jaw is a little bit more forward or their upper jaw is a little too far back. And what that can do is it can really assist with getting things to fit together nicely, and then lessen the need of potentially surgery or extractions down the road. Another thing that's very common that you'll see is rapid palatal expanders. So RPEs, and there's different variations of them, and I'm sure some people here probably had some when they were younger, and you may have them again. And this deals with the transverse, so the width. And the reason why this is so crucial is that we have a suture in our palate, and the suture, let's see if I kind of run it down right here. That suture will fuse after a certain age, and that age can vary a little bit, but it's lined up with when children finish puberty. So the suture can be kind of like this. If you see with my hands apart, And then what happens is it gets tight and it gets tight and then it solidifies. The reason why it's able, if you want to expand someone who's younger, is that you can not only get a dental effect where their teeth are getting apart, so they're no longer in that crossbite. You remember how I said how the upper jaw is in between the lower jaw, like the top of the shoebox falls in the box, not over it. But you can also get a skeletal effect, which means as you expand them like this, bone will then fill in. And so you can do basically what would require surgery as an adult, but as a child, as someone who's growing. And so this is something, people sometimes will say certain ages, and I've been guilty of this too, but really depends on when someone goes through that pubertal growth. Now, just to give you some examples, these are cases provided from some of my alumni, just because every time I move, I'm not always to take my cases with me or my photos with me. But here's a young girl who had, blocked out canines. You can tell she has some crowding, but she's got really good facial structure. And that's something that's really changed in orthodontics, is that we're really looking at someone's face. We study, and I even did this in my dissertation for my master's degree for residency. We really study, how does someone's face, how do they age? How are they going to look 5 years from now, 10 years from now, 20 years from now? Because we all know we're going to age. We all know that if we look at our grandparents, when they smile, they show more of their lower teeth, not their upper teeth. We know that there are certain features that will look different over time. And so when we're considering camouflage, we're considering this in someone who, like her, has probably already done most of her growth. And we're thinking, okay, is she someone that I need to do jaw surgery, or can we just use extractions and know that it's not going to harm her facial aesthetics, meaning it's not going to make her look older? And so what we did is we extracted 2 upper premolars on the top. And when we do, you can see how things fit together nicely, but she still looks like a very attractive young lady. And that's the thing that you always want to make sure when you're explaining treatment options to your patient, you're looking at a patient, is you're thinking, okay, am I making the face fit the teeth or the teeth fit the face, if that makes sense? So again, am I doing something that's going to still make her look good? And sometimes even when I go over options with patients and I maybe am not a fan of camouflage, or I am, I'll let them know and I'll let them know why. But ultimately in the day, being a good provider, being a good dentist means that you are explaining all these options to your patients and giving examples. Now, one thing you're going to see here is you're going to see right here, if you look at the molar relationship, and I'm not sure if you guys have studied this in canine relationship. So as orthodontists, we're very keen, we want to try to get more of a class 1 canine relationship. And what that means, it means your maxillary canine occludes between your mandibular canine and your mandibular first premolar. We're not so much as concerned about the molar relationship. So here she finished a full step class 2. And I say full step class 2, meaning that the maxillary mesiobuccal cusp, so this cusp is the furthest most forward, came a little more forward. But it's just something to show you how things will really fit together. And again, she's got a beautiful functional smile. She's obviously very happy. I would have liked not having her earrings in the photo because it's a little distracting. It's just me. And that worked. And here's another example, but the exact opposite, where this gentleman, he doesn't look like he has much crowding on the bottom as he does on the top. You can see his teeth are kind of blocked out. But again, he's got good facial profile. And when patients come to you, it's really important to probe them and ask them, like, why are you here? You're signing up to do this for a long time. Is this something you want to do? And what's their goal? What's their motivation? Because everyone's always going to ask, right after they get off their braces, they want to, after the braces go on, they want it to get off. And so that's what we did for him, is we took out 4 teeth. As you can see, fits together nicely. And again, I did put some YouTube examples here on the bottom. I don't know if it'll allow me to click sharing screen. It might, but I'm just going to show you guys what this kind of, video is unavailable. I'm so sorry. I will make sure to have some links. I might also be blocked because I'm in Japan, so it may read my VPN blocker differently. But I can also make sure to include some if that's something you guys are interested in. And it shows this. And that's what I do in my not private practice, in my military practices. I show people what it looks like, because it is kind of scary thinking, okay, this doctor wants to take out 4 perfectly healthy, good teeth to get my teeth here. That's kind of scary. So I think it's really, really important to show that. The next thing I want to show is orthognathic surgery. So what orthognathic surgery is the ability for us to actually surgically correct the jaws. And this young lady, as you can tell, she's got a lot of, some people may call that overbite, if it's overjet is what she has. And what we are doing is we're trying to bring the lower jaw forward. Now, if we took out teeth on her, if you look at her profile right here, it really is not going to do anything for her. And we also know over time that her nose is going to get better, cartilage proliferates over time. And it's not really going to give her a nice profile. So we actually presented doing jaw surgery to her. And you also can see she has a baby tooth down here where it's submerged. She doesn't have a permanent tooth. And we took out some teeth, and this is what she looks like. Totally different. Totally different. Now, if you can zoom in, you'll see that some of the roots here are on the bottom, and they're doing that to maintain the bone. And you can see all these plates in here, which looks really scary. But what you do in surgery is you're removing the compensations and you're bringing the jaw together. And it's full in the gene pool. It really is full in gene pool. And I always ask anyone, I think surgery has anyone had it? And this case was, again, treated by one of my co-residents who did an amazing job on her with the surgeons. And again, you can just kind of look at the before and afters. And again, I put some YouTube links here. If they don't work, please let me know. But the difference is that when we do surgery, we're removing the compensation. So if someone has an underbite, we're almost going to make their underbite look worse. So that way, when they break their jaw, things come together nicely, and vice versa. So she had a lot of overjet. We probably increased it. So that way, when she comes together nicely. And you guys can see the before and after is amazing. So that's something we do a lot in the military. That wasn't something I heard from your colleagues, because again, people are not paying for it. It's something we can cover. The main thing is just making sure they're there for enough time and coordinating with the surgeons. And the surgeons really are the ones who take it forward. Our goal is to give the pros and cons to the patients and let them know what they're signing up for, because it is still surgery. And I know one of the questions I always get asked is your jaw wired shut? Absolutely not. No. We do not wire jaws shut. Okay. What we do is we have a thin wafer. And is it going to be, it's controlled trauma. And one of the reasons our surgeons love doing this is that when they do have patients who come in who were in car accidents or had something that happened, these are cases where they can get good practice and making sure we give a beautiful result to a patient they wouldn't normally have otherwise. Another thing that we do in the military is we handle a lot of craniofacial anomalies. So we have a cone beam CT to our upper left that kind of shows things in dimensions. We have a young boy to our lower right. And again, this was one of the cases that came from the residency program that I was at. And it's something, again, I'm showing you different sides of what we do in the military. So if this is of an interest of you, this is something we definitely have people that do research, sit on boards and work with specialists. And these are the major hospitals. These are the major hubs where we do it. So for the Air Force, Wilford Hall, San Antonio, Texas, that's where my residency program was. Army, Tripler is located in Hawaii, and Madigan is located in Washington State. And for the Navy, we're located in San Diego, that's Balboa, Norfolk, Virginia, Portsmouth, Virginia, same area, and Bethesda, Maryland, which is outside of DC. And so we work with all these team members, and what they do is that they actually, someone who has a craniofacial anomaly will come for a day, and then all the specialists will rotate different in the rooms, and then they all come together. And it's such a beautiful thing, because now you're meeting in one visit, 20 different specialists at once. Then they go together, they come together, meeting of the minds, put together a cohesive plan, making sure that you stay on track and give you ideas on how to do things as you grow. And I'm going to show you guys just an example here of, obviously, one of the most common is cleft lip, cleft palate. And it's actually very common in Japan. So in the US, I believe it's one every, I think we said 10,000 births. In Japan, it's 1 in 500. And usually it's a combination of both cleft lip and cleft palate. You don't see it very often by themselves. And so this is something that we see and handle and juggle. And I even had a case myself in the military. The hard part of the military is that we move just as much as our providers, as our patients move. So we really strive in having a good pass off of care. And very often, some of my cases were handled by 2 or 3 residents, just because, like, you're going to graduate, you're going to leave, and unless you're in the same area, you're going to see these at different stages. But it is really quite fascinating to see these patients' journey and what you can offer them. One of the things, again, this is another great patient. And again, it's so important to take photos and document things, because you're going to see how different repairs heal, how different ethnicities heal, different severities. And, just to give you an example, I'm going to show you an example here of a young boy. This boy was actually in Afghanistan. I can't take credit for this photo. This photo came from Dr. Lisa Bronstrom. She's an amazing plastic surgeon, Air Force officer. And this patient was brought to her when she was in Afghanistan. And this shows what happens if someone didn't have the repair early on. And then here you can kind of see just different views of it. And then she actually treated him when he was 11 years old. So this is much later versus something treated at birth. And you can actually see he has a great result. So just showing you what some of the things you can do and be part of and compare. It's especially if you've been interested in academics or research, there is a place for that in the military for you to pursue and make a career of it. And so again, these are things that we do much younger. And again, I'm just showing you, it's important to understand these as orthodontists. You don't have to be as invested, and you're not going to be as subject matter expertise as, let's say, the oral surgeon or the plastic surgeon, but you're going to be part of the process. And how you're part of the process is that usually when the child's about that 7-year, 8-year mark, you may be helping to bring that upper jaw forward. And so this is protraction therapy. So this goes into one of the things where you as an orthodontist are going to play a pivotal role in this child. And this is an example that one of my colleagues had. And you can tell if you look at the profile, he's very, very flat. He's almost deficient in the upper jaw. And as you can tell from the intraoral photos of his teeth, you can see there's almost a little hole in his palate. It's called a fistula. You can see there's certain teeth missing, teeth that haven't erupted. And so what my colleague did for him is he got braces on his teeth and he put an expander in there. And this is a W-arch expander. And as he slowly expanded, because you remember bone, if there is not fully formed, you can tell that that hole, the fistula in the palate, got bigger. And again, that's what we do in the military. You're handling things that are not what you would see in private practice. And again, they were able to close the space and then get him ready for, and I'll go back to this. So what they were planning for is grafting to bring in his upper canines. And so what they'll do is now that they have the space there, they're grafting the bone for the canines to basically bring down into the arch. And so they're trying to save teeth. If we go back here, you're trying to save teeth that are up in the jaw to have bone with it. So one of the cool things about orthodontics is wherever we move teeth, bone comes with it. So if an area doesn't have bone and you can bring a tooth in there, guess what? It's like you building a house when someone told you couldn't build it. That's what makes it so awesome and so cool. So again, we monitor him, and then at a later age when he's done growing, because you've got to make sure a patient's done growing before you do surgery, then at least we're keeping him current to be ready for orthodontic surgery, corrective jaw surgery, and in what capacity that'll look like. So I've talked a lot today. These are my socials. I'm on Instagram. I'm on YouTube. Here's my Gmail address. And again, these are just different ways you can connect with me. And with that, I am happy to answer any questions you may have.
Wow, that was amazing. Thank you so much for the unique perspective. I know I learned a lot. And we do have some questions, so I can just start with that. Okay, so you said that you're always moving and because you're part of the Navy. So how do you guys, I guess, stay connected with your older patients, or how do you finish treatment and things like that?
So very often, and I would tell you, and this is true in the Army, the Air Force, the Navy, very often we're starting the same patients and we're finishing different patients. It's unless I start a patient right when I get there and I don't get cut out early, I may not finish them. So what we do is we try to do a good pass off. I have a good Excel sheet. I make notes. So whoever is replacing me, they have a good idea. And we just have a mutual respect among each other, knowing that, okay, you know what, you may take a case on one way and they may do things differently, and that's okay. It can be really tricky. I mean, I hear a lot of orthodontists say they don't like transfer cases, and I deal with them all the time. So I guess I've gotten used to it. But, some of my patients, they'll add me on social media. They'll follow me. I had one message me this morning who I was getting ready to take to Okinawa to get jaw surgery, and his wife had to, they had to get back to the States very quickly. And I was not able to continue his braces. He doesn't get care there because he's not active duty, but I coordinated with the oral surgeons there to coordinate that treatment. So it's a lot of emails, it's a lot of phone calls. I have a business card with a lot of my information on that I provided you guys. And every now and then things do slip through. I mean, we're all human, and I think it's just knowing that, gosh, I wish I could have done it differently, or, hey, listen, how can we make things better moving forward? And I think that's something that's really, really big. And we give each other a lot of grace. Moving around, especially during the pandemic, was tricky, especially for me in the military. The practice here hadn't had anyone for about 4 months. And so it was just going in and saying, hey, listen, I know it's been hard. I know it's been frustrating, but what can I do for you? And I made sure to meet with each patient. And if I didn't know what was going on, since that can be possible, you could always do a set of records. So the records would be like you doing something like this, taking photos, not just telling the patient, you know what, let's take a picture and see, does it make sense to continue the path we're going, or do we need to realign and kind of do a detour and get to the direction you are going? Because we're allowed to change our minds, and that's the beauty of orthodontics. It's very dynamic.
Gotcha. So I guess kind of going along with that, moving and going to a different country. So what is, I guess, the language barrier, and are there different regulations? How do you kind of navigate that?
Great question. Such a beautiful question. So in the military, we're only required to have one active state license. So it doesn't matter which country we're in. We're practicing on a base, which is considered the US. If I was practicing off base, I would have to get credentials in that country. I've never practiced off base moonlighted. I've done it in the States because I've got my license in California, Nevada, Arizona, and Texas. But also some of my state licenses will change the fees depending if I'm practicing, but you only need one. And then as far as the language barrier, all your patients you're treating on military bases overseas are either American, or they could be a combination of, like here in Japan, I have a combination children who are half Japanese, half American. And majority of them all, like I would say 99.9% of them do speak the natural language, do speak maybe the local language, Japanese and English. But if I ever find, because I do have 2 or 3 patients who do not speak English, either their spouses will translate, mom and dad will translate, or we will get a translator, because you really need to make sure someone fully understands what you're doing.
Exactly, yeah. And so communicating, I guess, the process, the treatment process, you mentioned camouflaging, which I guess can be hard to visualize even as a doctor, but what kind of techniques do you use to kind of really show the patient what they're getting into, what the end result could look like before they make a decision?
Yes, and that's a really good question, because I think that happens is, I have every patient sign a consent form that I do records on, asking if it's okay to show their photos, so I can always give case examples. Another thing that I do is in the program Dolphin, where we do a lot of our records, we can show the movements and what it looks like, at least from the side profile. So that would be from this angle. And sometimes that's really great. And sometimes I tell patients, this is just an idea of what things will look like. Especially I don't run into too much with camouflage, but I definitely run into it more with surgery. And if I find that they need a little more information, or if they're not sure, I have them meet with the surgeon. Now, I don't have an oral surgeon physically here, but with FaceTime, WhatsApp, I can have them do a video consult so they can kind of go through things, do medical modeling, which I know Dr. Eisenberg highlighted on, and that can really give a patient idea, especially if there's something other than their teeth, that they don't have a strong chin, or they don't like how big their nose is, or something about how just moving the lower third of your face can really affect the other facial features you have.
Gotcha. And so for surgery, is this like an oral surgeon that you kind of talked with, right?
Yes.
Okay, gotcha. Yeah. So the oral surgery, I'm sure, of course it's a surgery, but how is the, I guess, ranking of surgery, what the recovery time is? Like, is it a big surgery or?
Absolutely. I'll do my best to just tell you what I've had in my experience. And, I'd also say to ask the oral surgeons too, because they're the expert. But majority of my patients, I tell them, when we want to do orthodontic surgery, it takes about a year to year and a half to prep the case if you're doing surgery later, not surgery first. And I do a set of records. I present it to the board. I get the surgeon's recommendations. And then when they're getting close to the surgery, I'll do what's called a second look meeting. I take a second set of records and I present it to the surgeons. And usually my patients go down to Okinawa. That's where they go, because I don't have an oral surgeon physically here. And they're there for about 2 weeks. So they have to do a COVID test. They'll do some records, some medical modeling. Then the patient will have their surgery. And then they'll have the recovery time, which is about 10 days, give or take, depending on the type of surgery. Obviously, the more you're cutting, the more chances for complications, upper jaw, lower jaw combination. And then they'll be in a surgical splint for about 6 weeks. And usually I'm the one who takes it out just because of the location. But when I did work with surgeons, I did have them take it out. And what it is that before they go into surgery, we do put on what's called extra lugs. It almost looks like another set of brackets. And what that does is it just adds an extra layer of reassurance. So when their splint comes out at 6 weeks, we take that off and maybe replace it in the brackets. And then we have a beautiful thing called the RAP effect, rapid acceleratory phenomenon. So this is like you getting, versus, let's say braces is driving a car versus the RAP effect is getting in an airplane. You're going to get from point A to point B much faster in an airplane. And that's what the RAP effect does. So it's amazing when we can definitely capitalize that and really finish and detail a case much quickly.
Right. Makes sense. That's amazing. So you mentioned that you fell in love with the dark side of dentistry. So what kind of differentiated your journey with orthodontics versus oral surgery? Why didn't you decide to do oral surgery solely? I did actually have an oral surgeon write my record of recommendation for the Navy and for oral residencies. I am a people person, and I'm not saying oral surgeons aren't a people person, but I love to get to know my people. I love to be part of their family, be part of the team. And with the surgeons, you have such a finite period of time.
And I think I'm just too bubbly. I'm too positive, upbeat. And I don't know if they want the cheerleader there, the Susie Sunshine. But what I did like about them is I like being part of a team. I loved being in the operating room. It's been too many years since I've been in there, and I hope to go back for my next case where I get to see what they do and to know that, I pride myself on my communications of working with them and say, hey, listen, I know what you do is tough. You're in here for 10 hours. You can't eat, you can't drink, you can't go to the bathroom or anything. What can I do to set you up for success, to set our patient up for success, to have that smile they're going to be so proud of? And for me, it's going in and bringing my stuff and saying, hey, what can I do better? And very often I find that some of the areas that I'm overly critical of my work, they're like, no, it's fine. Like, doc, send it to us now. Like, they're fine. Like, we can help you fix this. But it's having that really good rapport. And I think it's just personality, and honestly, I have so much respect for what they do. Residency is tough, that lifestyle stuff. And for me, orthodontics really just seems to fit my personality of really, being that problem solver, figuring things out. 2 + 2 doesn't equal 4 in my world. It can equal 5, it can equal 7. And it really humbles you. The longer I've been an orthodontist, the more I realize there's so much that I don't know, but so much I can't wait to know and wait to learn.
Amazing. So you mentioned residency. So how would you compare residency versus dental school? What the, change in study habits, the pace of life, how would you describe that change?
So dental school, I thought was so tough. I felt like I think I lost like 10 pounds and I hadn't eaten anything because we would just drink Jamba Juice every single day, and that would be like our survival mode. And after the first 2 years, it got a little bit easier. And then I went to residency, and it was like, dental school was a dream. It was a walk in the park. I felt like I was drinking out of a fire hose for 2 years. I started waking up at 4:30 in the morning to study, and I would leave there at 10:30 at night. 2 years in a military residency program was a lot. It was a lot to take in. I think if we had a little more time, it would be nicer, but at the same time, you compound that with different branches of the military and all the things I had to do in the military. It was a lot, but I wouldn't trade it. I mean, I had 6 full-time attendees, and there was only 5 of us residents per class. So I feel like I got some really great one-on-one time. But because of that, I got a lot of one-on-one time.
Amazing. Yeah, that's amazing. So you said that your dad was part of the Navy and also a dentist, right?
Yes.
Okay. So I'm sure you had some, perspective as a kid watching him do his job. So what do you think, like when you finally were in the position, what do you think changed? Like how did your perspective change? What shocked you the most?
What shocked me the most was I realized my dad did a lot of things that a lot of general dentists didn't do from his time in the military. So my dad handles, doing retreats of root canals and temperamental disorder and other things that I learned that a lot of colleagues would refer out. Maybe that's because of his time in the military. And I would say another thing that I learned is, my dad was a general dentist for his full-time military. I became an orthodontist early in my career, was just how many opportunities there is to do in the Navy. Like right now, depending on the day, I am in charge of 60 people, or I am teaching, or I am writing up an award or report for someone. I'm doing so many different things that I didn't realize. And I have an opportunity to help people with their careers. And I think that's something that's so beautiful and can be so life-changing, because I don't know if I could be in the same place day in, day out doing the same thing. I know some people love it, but I really like the breadth and the depth the military really offers. And there's so much more to meet the eye, and it's changing. I mean, to do some of my passion projects, I'm not sure if I would have the time or capacity, because I don't see the same volume of patients, but my patients are more complicated and have more complicated situations than I feel some of my colleagues do in private practice. And that may be just location dependent too as well.
Gotcha. So for people who are interested in applying to the military scholarship, what is the process like? How can they set themselves up to be a good candidate for the scholarship? Do you have any tips for us?
Yeah, absolutely. Tons of tips. So I would say start talking to recruiters now. If you're interested while you're in college, good grades, good letters of recommendation, and you can actually start applying for the scholarship before you even get into dental school. So while you're applying to dental school, you can actually put in for the scholarship. So as long as you have your DAT test, once you get into dental school, you can have that scholarship lined up. So definitely the sooner the later. There's different versions of the scholarship. I don't want to confuse people, but 2, 3, 4-year options positions, and some where they pay you as if you're in the military, some that pay you like me, where it's more of a scholarship base. And I would say if anyone's interested directly, just message me and I'll make sure to get them contacted with the right people.
Amazing. Okay, so we have one more question, and I really want to talk about this, but your book, that's amazing that you wrote a book.
Thank you.
Like, I
Thank you.
can't even imagine doing that. That's amazing. So I want to know what the process was like, how you were inspired to write one, and I guess the timeline for that.
Sure. So I started this book a couple years ago. I was in Italy when the pandemic hit. And during that time, I met a couple other naval officers who were pilots turn physicians that had done the process. Because in the military, I did have to get permission. I got permission through the Department of Defense, pre-publication review, just making sure I wasn't releasing any top secrets and, what I was putting out. But also just the fact that it was really... it was something that I've always wanted to do, and something that I had a lot of people encouraging me. It is a labor of love. Some days you love it. Some days the words just don't come to you. You want to throw your laptop out the window. But my book is about my life, my story, and the lessons I learned along the way, and just how being someone who's a naval officer and an orthodontist and a beauty queen and all these things could be so different, yet they're so synergistic. They help each other. And it was really just going through my life and having people saying, no, I couldn't do this, or you can't do that, and learning that why should you let someone else dictate the limits of your life or the potential what you can do? Like, screw that. Like, you can change your life. You can make those changes. And honestly, most of the time, we're our biggest enemy, holding ourselves back. And it's learning to get past that and deciding, okay, I want to change. How can I do it? And I have some really great people who helped me. And that book, I started it in 2020, and it published, the digital published in April. And this past week, the paperback is available. So thank you to anyone who supports it. I mean, you don't do books to make money. You do books because you want to do it. And for me, it was just something I really wanted to share.
Yeah, amazing. Thank you so much. I look forward to looking at it. And thank you so much for coming, for all your helpful tips, your story. It's amazing. You wear so many different hats, and I'm just like so inspired.
Thank you. Well, you can too.
So thank you guys for watching. You guys can take the quiz, which we'll put up after for your virtual shadowing hour. But if that's it, thank you so much, Dr.